And good evening, Dr. Bill Tulo, CMO of Oculus, and welcome to the Oculus Clinical Webinar Series. Tonight, I am extremely excited to have our special guest speaker tonight, Dr. Paul Karpecki. A little housekeeping before we get started. If you have questions during the webinar, please place them in the chat, and we'll do our best to get to them at the end of the webinar. The title of our webinar tonight is DEWS 3, Where It Might Benefit Your Dry Eye Practice. I'm really excited since I haven't even seen the DEWS 3 report, so I can't wait to hear all the new updates. As most people know, Dr. Karpecki, he serves as the Director of the Cornea and External Disease at Kentucky Eye Institute in Lexington, Kentucky. He's an Associate Professor at the Kentucky College of Optometry in Pikesville, and he's chief medical editor of Review of Optometry and is on the board of the charity Optometry Giving Site. With no further ado, Paul, take it away.
Thank you, Bill. What a perfect introduction. Actually, to be fair, none of us have much familiarity with DEWS 3. It has not actually been released. In fact, this might be the first presentation in the entire country on DEWS 3 because the publication will go into print probably in the next 6 to 8 weeks. I was on the diagnostic committee for DEWS 2. I was on the treatment committee for DEWS 3. So the treatment committee, had to cover something like 43 different medications, therapies, treatment options, things like IPL, LLLT, that sort of stuff. And it was interesting because I was given like 7, next person was given 7. And then people were like, well, I don't know anything about this one. And so then Lynn would call me and say, Paul, can you cover this one? By the time it was done, I covered 23 of the 46 technologies. I'll never do that again. But it was kind of valuable to go into these at a good detail. And I had help. I had a resident who helped, an associate who did. Wasn't all on me, but I do want to take you through what we've learned, where it's practical, what this means. And there are parts when you look at DEWS 3 that you might question. There are other areas where I think are very important, which I'm going to highlight today. But no matter what, I'm going to save you reading like 1,100 pages of a document, no matter how we look at it. So thank you to Oculus. Thank you to Bill for the opportunity to get to present this. Thank you for being here. You're the first group in the country, perhaps, to hear about it. So what has changed from DEWS 2 to DEWS 3? Now you look at this and they look kind of similar. DEWS 2 definition was dry eyes multifactorial. That didn't change. It's a disease of the ocular surface characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms. If you go over to DEWS 3, kind of in the middle of this, it says it's multifactorial as well. It's of the ocular surface and tear film. So they added in the tear film, and it was in both, but the first one had homeostasis of it. This time they just said it was involved. They got a lot more into symptoms, not of discomfort, because that's kind of in there, but visual disturbances in DEWS 3. They really wanted to make the point that dry eye is a vision disease as well. That is, people who come in who aren't doing well after an IOL or cataract refractive surgery or contact lenses or even spectacle remakes is probably dry eye as one of the most common causes. They hit visual impairment, which wasn't in the first definition either. Then they said it's accompanied by ocular surface homeostatic dysregulation. They took out hyperosmolarity, and they went into neurosensory changes. So a little bit of a twist on it. I think the only major things are really getting into visual disturbances and visual impairment. They hit it twice. It wasn't like once was enough. They decided to put it in the definition 2 times. And then they really focused a lot more on neurosensory changes. While they were mentioned before, they weren't a focus. So it described dry eye in a couple of different ways. One, broader scope, as we talked about, including both levels. DEWS 2 is mainly on the tear film. The ocular surface is much more involved in DEWS 3, which makes sense. What I mean by that is looking at eyelids, expressing meibomian glands, checking for Demodex, all that stuff is a bigger part of DEWS 3. And then the big visual disturbance, visual impairment, making clear the image, the impact that goes beyond discomfort was the highlight. So a couple changes on definition, but I like them because I think it does allow some practicality in today's webinar when we get into looking at eyelids. One of the good things about the Oculus Keratograph is that it was already based on visual impairment. It preceded DEWS 3. They kind of like, hey, we know the important stuff way before these DEWS people will figure it out. If you look at the technology that's been around for some time, it only continues to get better and more refined and better resolution, but it's been in the Keratograph for a decade. That's how long I've been using it, or longer. And that's that combination of visual impairment associated with tear breakup time. That, and you can see on the bottom, the change in how it occurs and when it happens. So it makes it clear that the vision-related quality of life is impacted. That's what DEWS-3 did. And it's more practicable for clinical communication and patient education. That's saying the reason why you can blink that clear has nothing to do with your IOL or your LASIK or your spectacles or your contact lenses. That's really dry eye. And I can show you this on the Oculus Keratograph here by where these red spots are and how quickly your tear film breaks up within, about 4 seconds on that image below. So what are the key differences amongst this? And then I'll get into some real practical stuff. But the framework really changed a little bit. In DEWS-2, they included just aqueous and evaporative. Those are your only two types of dry eye. And that was my committee that was in that, and I complained about that ferociously. I know in my clinic, there's 4 types of dry eye. There's aqueous deficient, there's lipid deficient, which is evaporative. There's mucin deficient. Why do we leave out the poor goblet cells in DEWS-2? And there's exposure related, people whose eyes don't close well at night. Those are my 4 primary categories. Everything else is a differential diagnosis. And DEWS-3, even though I wasn't on the diagnostic committee, I had plenty to do on the treatment committee this time around. They got it. They said, okay, we're going to include not just mucin and aqueous and lipid. We're going to include those 3 of the tiers. We're going to look at the eyelids and how they close and what might be on them and how the oil glands work. And we're going to look at the ocular surface. So they took it to a much higher level. So it is more accurate, I believe, than it was before. If you look at lid disease is the primary driver in DEWS-3. That's a huge change. In DEWS-2, it was kind of a mention. And you know what's amazing? If you go back 22 years ago for the International Task Force, it was called the Dysfunctional Tear Syndrome Panel. And I don't know, was the panel that was dysfunctional or the definition was dysfunctional tear syndrome? Because we were pretty dysfunctional. But if you look at the very first, the abstract, which is the very first, kind of description of the publication, it basically said that lid margin disease was the least common form of dry eye. That means that just a little over 2 decades ago, we were completely wrong, 180 degrees off. We assumed that the rarest form of dry eye was actually, now we know it's 86% of dry eye. That's how wrong we were. So I say that not to put myself down, because I was on that committee too, or the committee, of which many people are well past that. The committee had people like Michael Lemp, who's passed away, and other great names. But the point being that I say that to tell you that we're always learning, that we're only advancing, that things are at a much higher level, and that if you make mistakes, you're allowed to, because the experts were completely wrong just 20 years ago. Neurosensory role is mainstream now in DEWS-3, and it was kind of a peripheral uncertainty in DEWS-2. Functional vision has become the core component of how you define dry eye besides discomfort in DEWS-3, and it wasn't even recognized in DEWS-2. It wasn't mentioned. Visual disturbances, that's not dry eye, that's something else. So mixed mechanism was implied, and now it's illicit. Nearly all dry disease is mixed. I don't think that's, I guess nearly all, that's true, but it's not all. It's not 100%. I have over probably 600 positive diagnosed Sjogren's syndrome patients in my clinic. I think it's the largest in the country because I was in a panel with a couple colleagues and ophthalmologists as well, and most of them were saying they had about 30 to 50 Sjogren's patients. And when I had to say how many I had, I thought, they're going to think I'm lying. But I had just pulled data because we're doing a study on Sjogren's KCS, and I just took our CPT codes out and I looked for Sjogren's KCS, and it was like 512 patients, and that was 2 years ago. So I got to think we've got to be at least 600. And I will tell you that at the beginning, when you first diagnose Sjogren's, it is pure. They have aqueous deficient dry eye, but if you let it go long enough, it becomes mixed because my meibomian glands have to run the marathon and make up for it, and they become damaged too. So DEWS-3 got that really well. And then systemic factors were not integrated in DEWS-2, and then autoimmune endocrine pain syndromes like neuropathic pain or chronic ocular surface pain are integrated into it. So a lot of changes in 7 years from DEWS-2 to DEWS-3. So what does it mean in our practice? What does it really matter? Well, number one is that it's going to be more personalized treatment. The days of saying, okay, you've got dry eye, here's cyclosporin are gone. Today, you're going to look at this and say, okay, you've got blepharitis, you got meibomian gland issues, and you've got staining. So yes, I'll use an anti-inflammatory, whether it's cyclosporin or lifitegrast, or if it's really bad, a steroid short term. But I'm also going to address why you're having problems. I need to get these oil glands better. I need to clear the blepharitis, whatever it may be. I need to get your eyes closed at night. That's the big invitation in DEWS 3 is, okay, let's address what's going on rather than just treating the downstream inflammation. I like it to a story I'd heard many years ago that's kind of a little crazy, but it was an example someone gave where they were pulling people out of the bottom of the river to keep them from drowning. And then someone finally realized, why don't we go see why all these people are falling into the river? And they went up to the top of the bridge. There was some guy throwing people in the water, and they just tackled him. Crazy story. But the point, it always stuck with me, maybe because it was so crazy, that maybe you got to go upstream and figure out why these things are happening rather than just treating the inflammation downstream or the bad tear film. And that's what's come out of DEWS 3 nicely. Better explains complex cases, patients with severe symptoms that have multiple issues going on. Signs and symptoms don't correlate. It's the only disease in all of eye care where as you get worse, you get less symptoms. If you had glaucoma and you were getting worse, you're going to lose visual field. If you have macular degeneration, you start losing that central vision. Everything gets worse when you have a disease of the eye, except dry eye. Your symptoms get better, but your visual disturbance gets worse. And that's why it became a big core of DEWS 3. It sports an earlier anti-inflammatory use, the days of, okay, let's try this artificial tear. Let's add in this compress. Let's put you on this nutritional supplement. Let's hope that patient comes back after the 4th visit, are gone. It's now, okay, we got to know that you're already using over-the-counter products. Let's get you onto something therapeutic. Intervention when homeostasis is threatened, not waiting for signs to show up. The aqueous versus evaporative is outdated. Now we're looking at whatever condition plays a role. And I'm going to explain that, how you know if it's mucin deficient versus aqueous deficient versus evaporative. And then emphasis on inflammation has kind of gone away to emphasis on treating the cause, but still managing the inflammation. So out of 1,000 pages, this is what stood out to me. I thought these were the most important things. And maybe I'm a little biased because in my clinic, this is how I run my clinic. So I was looking for these things in there. But nevertheless, I think this makes it much more practical. So I think you have to be able to discern changes from a visual outcome. You have to be able to look at the patients from an inflammatory standpoint, like red eyes means inflammation. So yes, I need to treat that with maybe a steroid or immunosuppressants, maybe even preservative-free Lumify. Why not? I didn't like the BAK in Lumify, but 3 weeks ago, preservative-free came along. That's a terrific agent for whitening eyes while you're working on treating the disease without the risk of BAK being involved. So here's what changed a lot is the whole area of dry disease signs and symptom overlap. Now, I don't know if this is completely accurate in terms of the overlap, because it seems like that's an awful lot of people with neurotrophic keratitis and an awful lot of people with neuropathic pain. I really think dry disease should be much more of that, and the little edges maybe are more the rarer things. But what they're trying to say is that you start with symptoms that are not neuropathic, but then and signs develop, and then the symptoms go down. And if you go long enough with inflammation, you're going to get neurotrophic, meaning you're going to get stain without pain. But there's also this thing we understand, this digital eye strain, which is more eye misalignment, where you get trigeminal overstimulation and you get migraines. It's also neuropathic pain, people that had multiple surgeries where the nerves have been shredded a little bit, and or chronic inflammation where the nerves have been damaged, where they have a lot of pain without stain. Dry eyes in the middle. You have to have signs and you have to have symptoms to be dry eye. And I do agree with that. If I had tons of staining grade 4 with no symptoms, that's NK. If I have tons of tons of symptoms without signs, that's neuropathic. If I have tons of signs like SPK with no symptoms, that's neurotrophic. And then there's differentials. Could it be allergy? Could it be blepharitis? Could it be an infection? Could it be limbal stem cell deficiency, etc. And I'm not going through this with you, but I thought it was valuable to put up the differential diagnosis of dry eye table. At looking at, hey, what if it's not dry eye? What if osmolarity is normal? What if expression looks really good? That's why you have to express. All these other things, what else could it be? And if it's related to the ocular surface, you want to look at the limbal stem cells. You want to look at episcleritis, mucus fishing syndrome, ocular neuropathic pain. The reason I put this in is to give you a little guide to to the best, I mean, the best dry eye specialist in optometry earn their keep here. It's not saying, okay, you got dry eye, let me put you on medications. It's when they don't have dry eye and you figure out what else is going on that really separates the best practices, I believe. So that this is valuable. Also, this was my section in DEWS 2. And I covered most of these in DEWS 2, but I love how they've tabled them into these really good individual areas, key features. They just improved a bunch of junk, not junk I did, it was really thorough, but I just had words. And I just went through every differential. And these are all the things you can look for. I love how they channeled this into a really nice document while it is complex that really goes through everything. And then the last thing before I get into the clinical applicability of this is I do love how what we talked about earlier. If there's no signs, but lots of symptoms, think about neurotrophic causes, neuropathic causes, like the pain without stain. Think of all those other issues. So the X is no signs, just a lot of pain. And the X is no symptoms, just a lot of signs. That's neurotrophic. And that's another way of looking at it at the top. And then if you have signs and symptoms, you've got dry eye disease at some level. But what I do like about this is, yay, they include the goblet cells finally. We didn't just say, like DEWS 2, you can either have lipid deficiency or aqueous deficiency. I mean, there's only 3 layers. Well, one's kind of a combination layer, the muco-aqueous, but there's only 3 components of the tear film. There's oils, there's water, and there's mucin. I always felt kind of sad for the goblet cells, why they got left out. So I love seeing them in here. There is no question there are patients who have mucin deficient dry eye almost alone. And so I want to get into that. The second thing is the focus on the eyelids. This was really emphasized a lot. Could have been emphasized even more in my opinion, but I'm going to do it in this presentation. Looking at blink closure. The number one cause of non-responsive dry eye are eyelids that don't close at night. Korp showed this 22 years ago, 23 years ago. He was so advanced. I mean, he found out stuff that if you look up his research, you're like, oh, I thought someone discovered that last year. He was writing about it 25 years ago. And so his knowledge of inadequate lid closure was huge, and we're going to go into that. The next thing is looking at the ocular surface for staining, breakdown as really important. And then finally, any sort of associated systemic conditions like Sjogren's syndrome, thyroid disease, etc. So one of the things that I wish they'd pulled out more, but I felt like it was in the DEWS 3, was this thing about looking at the eyelids better. And the reason I say if you're going to get into dry eye or you already have a dry eye practice, you want to enhance it, begin with the lid in mind. That's 86% of dry eye has some sort of eyelid margin involvement. Sometimes you get an automatic answer. In fact, if you ever see a frothy tear film, you've got meibomian gland dysfunction. What's happening is the lipids, which are dysfunctional, are reacting with enzymes in bacteria, which could be alone or harbored in Demodex. But you've got enzymes there that then produce this saponification or soap. One of the great things about dry eye is that it really is an easy disease to manage. I saw 60 patients today. I don't have to dilate people. I don't refract. I don't have to look in the back of their eye. I'm looking at the ocular surface on every patient that walks in. And 60 is not a great feat when you're not doing much work. I'll show you what I do for my testing in a moment. So the great thing about dry eye to me is how it all lines up. Like a person who comes in with frothy tear film, which is caused by soap formation, also happens to have complaints of burning and stinging, like they got soap in their eyes. It's fascinating how all this stuff works together. But my point is you want to look at every sign of the eyes. Like I want you right now, as you're in this presentation, to look at that eyelid and say, okay, rather than what I did in school is we used to look at the eyelid only to go past it, to look at the cornea and the conjunctiva and the anterior chamber and the angles and all the stuff we did back then. We kind of skipped over the eyelids. So today we're going to say, okay, how important are the eyelids? I want you to look at this lower eyelid only for now. Tell me how many signs of pathology you see. I'm going to give you about 10 seconds. You can put it in the chat. You can write it down yourself. You could just yell it out because no one can hear you because you're on mute. Whatever you want to do will work. All right. Let's see how many of these you got. How many got collarettes? Now I know collarettes a little tricky, first one, because usually you look at that on the upper eyelid, but hey, we happen to have some on the lower eyelid too here, indicative of Demodex. How many people got these telangiectatic vessels, which tell you you've got ocular rosacea? Probably a lot of you. How many people, this isn't, oops, I'm missing a D there. Scalloped lid margins, kind of hard to see in 2D. A three-dimensional image, you would have seen the scalloping a little better, but that is there. Capped glands, that's what those white things are at the back. Also notice how posterior those glands are. That tells you you've had this a long time, as well as tylosis or thickening of the eyelid. Tells you it's been there for decades. Look at the debris in the tear film. For those who really know their eyelids, that posterior capped meibomian gland over here on the right, the fact our meibomian glands actually start in the anterior 1/3 of the eyelid. And if you've had MGD for a long time or rosacea of the ocular rosacea, it moves backwards. So see how far back that gland is? That's white and capped. This patient's probably had this for 20, 30, 40 years. Upper eyelids are certainly better for collarettes, where you can have the patient look down and look in there. What other condition does this patient have when you have them look down? Yep, ocular rosacea. Look at those blood vessels. It's just amazing what the eyelids tell you when you take a little time to look at them and how important they are to dry eye management. And then you got to express. I was doing a lecture at the Ocular Surface Symposium in Chicago earlier this summer. Great program, 100 full day of, hey, here's how you build the best dry eye clinic ever. And it was a fun day of that sort of thing. And I remember 6-7 years ago asking how many people express meibomian glands, and even the panel didn't put their hand up. And these are supposed to be the dry eye doctors on the panel, let alone the audience. Today, I asked that question. Of course, these people were coming in to learn how to build dry eye clinic, kind of like tonight's lecture, but it had to have been 80% of the hands. Now, whether they're just saying that because they wanted me to, they knew I wanted them to say that or not, but it was a really positive sign. Because if I go back like 8 years ago, I remember doing having a, I don't think it was an intern. I think it was actually a doctor visiting, and he came in and he got through the dry eye stuff, and he said, Dr. Karpecki, I loved it. Everything I learned today is amazing, but do I have to do that expression part? And I mean, expression's easy. All you're doing is you're just, well, let's look at it here. You're just taking a paddle or your finger, you're pushing upwards to kind of milk the oil glands, and out comes oil. And if it comes out like olive oil, fantastic. And if it comes out like toothpaste, that's bad. And comes out gelatinous, that's not great, or turbid. And if it doesn't come out, that's even worse. It's a 5-second test, maybe a 2-second test if you do it right. You only do it in the lower eyelid. You only do it in the nasal to central area. Anyways, he said to me, well, do I have to do that? And I started thinking about that. 86% of dry eye involves the meibomian glands or blepharitis. So that's like saying, I really want to get into macular degeneration, but do I have to look at the macula? This is 86% of dry eye. You got to see what's coming out to know what's there. And Korb, again, I know I quote him probably. I've had one lecture where I rarely look at comments because I don't know, I'm too old for that. Doesn't matter anymore. I remember reading them all when I was young. There's constructive ones, so I hate that. So I should look at the good ones and kind of use them constructively. But anyways, I was looking at one number of years ago where they said Dr. Karpecki he quotes Donald Korb way too many times. The guy just, there's no publication that came before him on this stuff. So there's no one else you could quote unless you want to quote someone who repeated what he did. So his name comes up an awful lot. But Korb said 78% of the time, you wouldn't even know they had MGD unless you pressed on their oil glands. And then the other extremely valuable tool is something called meibography. It just is, and the reason I say it's extremely valuable is because when I show a patient their meibomian glands and I show them what normal is, and this is what you've got, I keep my IPL running. And not because I want to running for my sake. There's no better treatment that I have for these patients who've lost glands to keep them around, keep the glands around, not the patient. And so I really do feel like it's something they need to do so they don't lose the remaining glands they have. Pictures are worth 1,000 words. Meibography tells me what I need to tell patients. And again, back to Korb. Don't say he quotes him too much, but he did a study a number of years ago that showed you only need 5.5 glands out of 54 glands in the upper and lower eyelid in order to be asymptomatic. So even this patient who looks miserable because they have so few glands could still function well in the hands of a good doctor like all of you on a call tonight. So one of the keys to dry eye is efficiency and accuracy. The quicker you can see 50, 60 patients, the better you're going to do. And if you're in a primary eye care clinic, I don't expect you to, because you got to do all the other stuff. You have a much harder job than I do. My clinic's 100% referral, and all I see is cornea and ocular surface disease all day. So I have it kind of easy. I need efficiency because of the sheer number, but I still think in a primary eye care clinic, the faster you can get through your dry eye patients, the more time you have for everything else. And we've made dry eye a little complex, and yet it's really a straightforward condition where the puzzle pieces always seem to line up. For example, upper eyelid meibography might be more important than lower eyelid meibography. Getting to know where a patient's at, taking the time to explain what's going on because you have images makes life a lot easier. The patient in the top, I have a little more time to do Bruder masks and debridements and MIBO, whatever. The patient in the lower left, I don't. I've got to do an IPL to get that controlled so I can control those glands and not let more of them fall off. Or this patient, who's a different patient again, who just has a few nubs here and there in various places and none in the other eye. Everting the upper lid is important. Use tools if that helps you to get a third hand involved. There was a study that showed the upper eyelid was more valuable. This isn't DEWS 3. This is a side. There's a paper I just finished that showed that it shocked me. So I put it in this presentation because DEWS at least talks about the importance of the eyelids. So I'll put it here. But the number one indicator of who's going to drop out of contact lenses was upper eyelid meibography. The number one indicator of who's going to get dry eye after cataract surgery was upper eyelid meibography. Sjogren syndrome patients lose their upper eyelid glands before their lower, even though that comes later than aqueous deficiency. And thyroid disease patients lose their central upper eyelid glands. And it was pathognomonic for thyroid eye disease when you see it. So here's the papers to go along with that. What they found with contact lens dropout, if you want to get into it more, there are individual breakdowns and studies of each one. The surgery-induced studies are here, including patients who had dry eye symptoms following cataract surgery had far more pathology in the upper eyelid. The lower eyelid was not relevant to that. Sjogren syndrome patients begin to lose glands in the upper eyelid first. As I said, thyroid has a very unique pattern of upper eyelid gland loss centrally, probably because of proptosis there in Graves' disease in particular, that you don't see temporal or nasal, that you don't see inferiorly. So that's why something like the Oculus, again, is so valuable. Just the quality of the imaging, the ability to see that, to look for if is it a contact lens patient likely to drop out by looking at the upper eyelid. Lower is easier, lower is valuable, but upper can still be a better differentiator for things like that, or thyroid disease, etc. Hey, this is a little bit of DEWS too, so not to make things confusing, but they didn't really have an algorithm for dry eye testing in DEWS 3. They did in DEWS 2. And DEWS 2 basically said, here's the way to diagnose dry eye. Make it easy. Get your meibography, get your non-invasive breakup time. And if you're really into dry eye and you're trying to build a huge clinic and differentiate this disease from other differential diagnoses, osmolarity helps. And I totally agree. Those tell you, yes, I have dry eye or do not. It's kind of interesting because I'll ask residents, I'll say, what's the best test for lipid deficient or evaporative dry eye? And they'll say, well, tear breakup time. And I'll say, well, what kind of tear breakup time would you get? And they'd say, oh, probably in a bad patient like rosacea, maybe 2-3 seconds. So, okay, what kind of breakup time do you get for Sjogren syndrome, KCS, which is aqueous deficiency? And they say, oh yeah, probably 2 or 3 seconds. I said, yeah. What about a real severe mucin deficiency, Stevens-Johnson's, graft versus host disease, or just severe SPK of the conjunctiva? And they get it by that point. They kind of smile and say, oh yeah, 2 or 3 seconds, right? I said, yeah. I said, it doesn't tell you which type of dry eye. It just tells you you've got it, but that's valuable. But non-invasive is far more valuable than invasive. Invasive means put fluorescein in, wait a full 2 minutes, let it equilibrate, get your stopwatch out. No one has time for that. Count the time, compare it over time. Non-invasive is the way to go. That's where the investment in the Keratograph is so valuable. Osmolarity is really for the high-level practices, but it's a great tool. Then when I walk into my clinic to see patients, they've completed these extensive questionnaires, but I just ask, what's your worst symptom? Because I want to improve it over time. And when do you experience it? Because if they have dryness in the morning and redness in the morning, that's not dry eye. That's just eyelids that don't close. So knowing the time of day is so valuable. Then we do the eyelid assessment we just did. We look for telangiectasia and capped glands and scalloped eyelid margins and debris in the tear film and thickened eyelids and where are the glands? Are they posterior? And we look for collarettes and we express, see if they've got toothpaste coming out. Then I put a little fluorescein in with my number 15 yellow rat filter. I can see conjunctival staining, corneal staining, and I could look at the height of the tear meniscus. Now, I don't measure it, although you can do it with the Keratograph, which is so valuable. But I get good at knowing a normal tear meniscus from not. Now, if you want to save time, just take a look at the Keratograph measurement, which tells you specifically if it is 0.2 millimeters or above, which is normal, or is it lower. So tear breakup time with fluorescein has not been shown to be extremely accurate, although it's still valuable. It just doesn't tell you the type of dry eye. No tear breakup time does. But these non-invasive tear breakup times are the DEWS recommended diagnostic tests for dry eye. So if you want to go off the DEWS too, and I wasn't on this last diagnostic committee, but you will see it's written there as the recommended test for knowing they have dry eye. Not the type, but knowing they have it. Then you could figure out the type based on what you get there. So that's why this is so helpful to showing the breakup time and what you see. Also for monitoring improvement over time, and this is the kind of results you want. I still like stain because it tells me, what I'm dealing with on the ocular surface. If all the dryness is at the bottom, that's probably exposure, nocturnal exposure. Thin tear meniscus height, that needs to have a punctal plug put in of some sort. There's all kinds of good ones. Both eyes have really thin tear meniscus height. You could also get that measurement, as I said earlier, off the Keratograph. Conjunctival staining, look at how good the staining is. That's with the number 15 yellow rat filter. A little conjunctival chalasis folds at the bottom, which we can address as well. So corneal staining, which you can capture on your Oculus Keratograph, so valuable for monitoring these patients, for seeing the amount, for grading it, for all that's involved and where it's at. So treatment has taken a little bit of a turn when we get to DEWS 3. While they did state dry disease is still multifactorial, I hate that word because it sounds like it's complex. And dry eye is not, I say I've been doing this for 28 years, so I shouldn't make it seem like it's so simple. If it took 27 years for me to figure it out, it couldn't have been that simple then because I'm not that dense. But the fact is that now that I kind of know what's going on and I've had about 10 or 12 years of really successful clinic. I think I have the largest clinic in the United States in dry eye. In fact, I'm positive of that. Now, it has gotten to where it is straightforward. Like people who wake up with symptoms in the morning just don't have eyes that close, and we'll go over that. People who have a dry eye later in the day tend to have evaporative issues, especially if expressed through glands and it comes out like toothpaste. Or mybography shows that. Patients with conjunctival staining have mucin deficiency, and then you can address how to take care of that because that's where the goblet cells are. Aqueous deficiency is defined by possible staining on the eye or just a really thin tear meniscus. So everything kind of ties in so beautifully when it comes to dry eye. And at least that's what they did in DEWS 3. They talked about these multiple drivers like tear film instability, lid disease, blepharitis that coexist. They looked at the role of neurosensory dysfunction, which is kind of like the longer you have the disease, the less symptoms you get. And then targeting treatments that are not just an inflammation, but why do you have the inflammation? Why are these people floating down the river? Let's go up there and figure out what's happening way up on the bridge and take care of that aspect. So here's a patient with morning symptoms. You simply darken the lane, grab a pen light or transilluminator, tell the patient to close their eyes like they're resting peacefully, not squeezing. You put your pen light up here and you look for light coming down on the cheek and you can't miss it. It's almost like a party trick that they're like, wow, look at that light coming down. I could park a little truck right in there. It's just so big, some of these openings, you wonder, no wonder they've had so many dry eye symptoms. The great thing about inadequate lid seal, again, it's a term coined by Korb, is that they get three things. They get Demodex blepharitis. I don't know the association, but 98% of them do. They get MGD. I do know the association there because your meibomian glands recover overnight when your eyelids are sealed. And you get exposure keratitis eventually and fairly. And what we're talking about is not an eyelid up here and an eyelid down here. That's a rare disease called lagophthalmos, nocturnal lagophthalmos. We're talking about the fact that your eyelids are supposed to seal at the tip, and people with inadequate lid seal have this. So when you put the transilluminator or pen light up here, the light comes down the bottom, just like that, or that, or that. Number one cause of non-responsive dry eye. So what does DEWS 3 say? Okay, now we got the diagnosis of whatever the cause. And that's just one example of a cause. The question now is, how do we treat it? Stage one is education, environmental modifications, and ocular lubricants. Here I'm lucky again. I have a referral clinic my colleagues have done such an amazing job. Actually, in my community, I have like 8 doctors who have dry eye clinics in Lexington. And people think, well, it doesn't that bother you? You've trained these doctors and they're building these really successful dry eye clinics. Are you kidding? It's the best thing ever. They send me the toughest stuff. I don't have to worry about stage 1. I never have to educate about an artificial tear affecting your environment. They've already done all of that. They've already started them on things. And most of my colleagues are way past that now. They're into stage 2 and stage 3. And then I try to figure out what these other things might be that didn't respond. And so I do think this is definitely primary eye care level, that we need to be at stage 2 almost out of the gates, and stage 3 and 4. And one of the cool things about punctal plugs is, how do you know when someone should have punctal plugs? Well, after you've treated the eye for a bit, cleared up the blepharitis, treated the allergies, whatever it might be, treated the inflammation, if that tear meniscus is low and your keratograph says it or your stain says it, those are your best punctal plug patients. They love it. I shouldn't say this because I'm probably going to have a patient. Well, I don't have any more patients the rest of the week. I'm off tomorrow and next day, but I'm going to have a patient next week that'll come in miserable after punctal plugs. But I haven't had a patient complain of punctal plugs in 2 years, because I don't put it in eyes that don't have a really thin tear meniscus. So I don't get epiphora if they've already got this really scant tear meniscus that I'm treating. Stage 3 is oral secretagogues and serum, and stage 4 is surgical, long-term steroids, etc. And here's some little tables that take you through what can you do if it's lipid deficient. And again, this isn't published yet. You're getting this pre-DEWS 3 publication. What do you do if there are eyelid abnormalities like Demodex blepharitis, like inadequate lid seal? There are lid seals you can wear at nighttime, by the way. There's Xdemvy that you can treat for blepharitis. There's all kinds of cool things that have come along. What do you do for staining and injection? Like your preservative-free Lumify, your steroids, your lifitegrast, your new perfluorohexyloctane, which is Mibo, or when you have staining, your perfluorobutylpentane, which is Vivi, with cyclosporin. Those are amazing innovations. That's the best cyclosporin I've ever witnessed in my life. So it's incredible, these new innovations and how well they've done things. And then, monitor for success. Sometimes you're going to see improvement in signs way before symptoms. And you just have to tell patients, the longer they've had the disease, the longer it takes for symptoms to improve. And the reason why is, when your nerves are in a salt bath, which is what hyperosmolarity is, DEWS 2 definition, they don't recover until you make that environment perfect. And then 6 to 8 weeks later, they start recovering. That's why symptoms are the last thing to improve in these severe chronic dry eye patients. It also teaches us something else. If you treat dry eye early, symptoms are the very first thing that improve. So it's interesting how, depending on when you catch them, the state of the nerves, how the eye responds to healing. So monitoring improvement is really valuable in those patients whose symptoms haven't improved, but their signs have, because the symptoms will catch up. And that's where education, doctor to patient, is really valuable. So practically all the key testing that's recommended in DEWS 3 happens to be within the Keratograph M5. That is lucky for Oculus, but it's exactly the way it is. And while DEWS 2, I did a lot of it. That was my committee I was on, and I loved that this did the same thing. DEWS 3, I did not. They took it from that, and they still have that same recommendation. The type of dry eye is still important, but it includes mucin deficiency. You need to treat the cause, not just the inflammation. Causes could be inadequate lid seal, Demodex blepharitis, allergies. There's a whole bunch, MGD. Differential diagnosis is important too, but that's where things like Keratograph M5 and even things like meibography of the upper eyelid help to rule out when it's dry eye versus when it's not. And then pictures are worth 1,000 words, so communicating what you see on the Keratograph goes far. Before I do thank you, let me get Bill in here, and then we're going to go through a bunch of Q&A for maybe the next 20 minutes or so. Bill.
Sure, Paul. Thanks so much. Wow, I need to go back and rewatch this. There's so much there. And to that point, we had some questions regarding that. And yes, a copy of this webinar, a link, will be sent out to everyone registered in about a week. So if there's anything you missed, or any screenshots you didn't catch, we will send a link out to everyone registered, so you can rewatch this, like I will be rewatching it also, to
Just don't
catch
send
any
it to
things that I didn't get.
Yeah, just don't send it to the people who are the lead authors. I'm the fourth author on DEWS 3, because It's not just not yet published, but I love the fact that we get to talk about it first here.
That is a deal, Paul. We will not do that. So first question I have is something that I'm surprised more people didn't ask, but um, why was osmolarity taken off of DEWS 3?
I have no idea. In my opinion, if I had nothing more than the Keratograph and osmolarity, I could run any dry clinic anywhere. I would know enough to know, hey, this is not. I wouldn't have to do anything else. So the thought of removing one of the more valuable tests for a secondary care clinic, a referral clinic, a primary eye care clinic that has dry eye as one of their quote subspecialties, that makes zero sense to me why that was removed. I don't know. It could have been related to just politics, could have been related to making it easier, addressing more doctors in case they don't have it. That is such a great question because one of the first things that I noticed when I looked at the definition myself.
I'm going to ask you a question of my own, only because I had this patient Monday night in my clinic, and I get these patients from time to time, and they're frustrating, and it's patients with conjunctival chalasis. Do you have any recommendations for non-surgical treatments? Because finding surgeons that will do the treatments is not easy. I do have one or two that I need to make them travel pretty far to get it done. How do you handle yourself these patients before punting to surgery?
Sure, sure. So a couple ways of doing it. First, believe it or not, one option is a short-term steroid, like about a month. Believe it or not, with an alpha adrenergic agonist like Lumify, I'm not trying to promote that, but Lumify being an alpha 2 receptor agonist can actually create a little bit of tightening besides just the whitening from a little bit of the oxygenation it produces by constricting the veins, that you can actually get a little benefit. Now, patients, originally I thought, well, that's just because you're making the eyes whiter. But no, and when I look at some of these patients over a period of time, again, this would only be mild CCH. You're not going to get this for severe CCH. You're not going to see a difference. But in the mild early cases, that combination does help because chronic inflammation is the cause of why we lose tenons, and that and the benefits of something like Lumify, especially now this preservative free, are that it can help with the overall not just inflammation but oxygenation of that surface by constricting the veins. So that's one option. Option number two is to look for SLK. Many times when you see conjunctival chalasis, you look up top under the eyelid, people just fail to look under the eyelid a lot, I think. And you see SLK up there when you put your fluorescein staining in. And what's happening is the bed sheets are too loose, so at the bottom they're loose too. And one of my favorite ways of healing these patients is to do a low temperature cautery. And again, you got to be in a state you could do that. Kentucky's great for that. I just have the patient look down, and I do a lot of anesthetic, like on a squeegee on top of the upper eyelid, just on the upper area. And then I use low temperature cautery, not high. Never use high; that would leave scars. Low temperature cautery, and I do 1, 2, 3, 4, 5. About a millimeter later, 1, 2, 3, 4, 5. Millimeter down, 1, 2, 3, 4, 5. And I leave about a millimeter or two from the limbus for safety. And it stretches the bed sheets. And I swear, I've had patients who are so photophobic who couldn't open their eyes because of SOK with conj chalasis. I saw one today and wide open, says the best I've ever felt, Dr. Karpecki. I can't believe I'm going to work. I'm good at the end of the day. I've only done like about 8 now, but all 8 have improved. And then one more thing, I'm glad you asked. There's a product coming out in January that I did the research on called Silk Tears. It's made from the silk fibroin. It's a incredibly anti-inflammatory. It's a mucomimetic. It's the first drug that targets conjunctival staining and damage, which is what conj chalasis will often have. I saw it clear SLK and improve conj chalasis in 3 weeks. You know how long it takes me to treat SLK before doing? When I do cautery, it pulls up the bed sheets, and so everybody feels good, but the staining doesn't go away. It could take me a year or two on steroids, on VEVI, and on vitamin A, like hyalonite, to get that conj improved. And with that Silk Tears, it was gone in 3 weeks, twice a day. So that's supposed to come out in January as an over-the-counter product. So you've got 4 treatments there, Bill, that depending on the severity, you can look at using.
Wow. I'm excited to hear that, and I'm excited to try it when that does become available. We have a couple of questions, and I'm going to try to combine them together. Um, Regarding the clinical evidence of things like IPL, RF, LLT for treatment of dry eye, can you just give your opinion on what is really out there, and how do
Yeah.
you use those technologies for your patients?
Great question, Billy, because you know me, we've known each other for a couple of decades. While I am optimistic, I tend to be a skeptic. I'm like, show me why this would work and stuff like that. So IPL was one of the first ones to really that I kind of looked at closely. And I've had three IPL systems, so I've had practice. I don't have the Darwin; it is on my wish list, but I've had three over the years, which is great because a few people have more than one. And what's really been confirmed about it is that it's one of the few conditions where I can take a person with zero expression and make their glands work. I've never been able to do that with a LipiFlow. I've never been able to do that with the other things. I can improve on poor MGD function with like tear care, LipiFlow, whatever, but I cannot get zero expression to work except through an IPL. So I've become a big believer. Best patients are those who have the telangiectasia, the rosacea on the upper eyelid, on the margins, because you shrink that down. And I do believe that their eyelids do tighten because I have patients come back and say, Dr. Peggy, I just feel like, my eyelids are in a better spot, or I have less wrinkles over here, which is a good selling factor, but it mainly means that I'm tightening the eyelid to where the blink's getting stronger, and maybe that's helping to pump the meibomian glands out. It does take 4 treatments separated by 1 or 2 weeks to get that initial effect. 92% of my patients get all they need in 4 treatments. 8% need a fifth, so I usually don't charge for the fifth because it's only 8%. But I've had some need 7 though and 8, so there are those ones that are really bad rosaceas that don't quite get there. But my point being, there's a lot to that. I do find that combining an IPL with another technology, be it RF or LLT, further enhances the effect. There's something to be said for that additional treatment that works from a different mechanism afterwards, more of a heating effect, more that works outside of just ATP, more on the endogenous heat that is produced by the body. So I think I do feel like when I have any of those additive ones, they do seem to improve things a little bit better than just the IPL, although IPL still does an amazing job in of itself. And then finally, you know, the expression tells you the answer. If you see a lot of rosacea, that's your way to go, is the IPLs with those treatments. The other big advantage is that I'm a big fan of the Bruder mask and hot compresses, but I'll tell you, if you have a lot of rosacea, it does make the rosacea worse. That heat doesn't help them. They get a little benefit of the oil glands, but the trade-off is worse rosacea. So having an IPL with RF or with LLT or just the IPL is a far better option for those rosacea patients. So they don't have to do those heat compresses. Now, if they don't have rosacea, go all out with the Bruder mask. Patients love that thing, and you're fine. So it's really taught me a lot of how to use things where, depending on the patient type, and therefore in rosaceas, in non-expressive glands, there's no better treatment than that route. If I express glands and stuff comes out, but it's not great, then you could do tear care, you could do lymph flow, you could do eyelids, whatever your other things are, manual expression. But those non-expressors, those rosacea patients, those tough to treat, there's nothing better than IPL with a combo.
Question, in your opinion, regarding mybography before and after IPL. Some people say that not only do the glands produce better oil, but you actually see wakening up of meibomian glands. What's been your experience looking at mybography before and after these treatments?
Whoever asked that question knows their stuff. Another thing I was skeptical of. I'm like, you're not bringing back atrophied glands. I'm sorry. And then I started seeing some glands coming back and started analyzing this, and I realized I was right. Atrophied glands don't come back. But what's happening is these were live glands that were not perfused, and they were just not being picked up on mybography, or just the angle. And again, this is a little bit of a compliment to the Keratograph. It's so accurate in terms of the angle that it captures mybography that it doesn't tend to miss a lot. But there are other mybographers that I've had where when you change the angle, it looks like the glands have come back. It was just the angle. But the number one cause when you have a good system like the Keratograph where it doesn't have angle issues is you're reperfusing those glands after the IPL. They weren't really atrophied. They were there. There was just nothing in them. and by reperfusing them, they show up. Because I've seen truncated ones that got longer, and I'm like, I just can't imagine that they've grown from where they were. It just reperfused. That's all it was. And so we're still trying to figure and understand this area. But yeah, I was wrong. I thought that it was impossible for that to happen until I started seeing a whole bunch of them and realized I believe what's happening is we're making the glands function, and now we're seeing the gland with lipid in it, and that's creating the image of the meibomian gland that now shows up on meibography.
I know punctal occlusion has been around for decades. It's not a new procedure, and for the right patient, it can be really, really effective. Do you have
Yeah.
any favorite products now? Do you go straight to silicone? Do you do only collagen? Do you do the extended only? What do you do now? What's your current
I love
protocol?
this. Bill, your questions are fantastic. I've become a real big fan of punctal plugs again. I went from a time a decade ago where I was like, I don't know, I just plugged like 20 people a year. It was like really rare, and I took more out than I put in. Somewhere in about the last 4 years, 5 years, I've put in hundreds, and the patients love it. They're like, Dr. Reggie, why didn't you do this sooner? I'm like, well, the earlier ones rubbed on the eye or they wouldn't stay on in, and those were your silicone. It was really hard to some patients, it would irritate the surface. In fact, I had a patient a couple weeks ago where she's like, I just have a lot of discomfort in the corner. And I looked at her plug and I took it out. She immediately called Carla back, said, my eye feels great. Those still happen even to today. So what has changed in the last 4 or 5 years? Two things. One is there's putting a plug into the canal is dangerous, like the old smart plugs and
The hair
things like
plugs.
that. Exactly, hair plugs. So now you've got a risk of stasis of material, which leads to bacterial inflammation, canaliculitis, and it's hard to get those out. Those are never a recommendation. But surface plugs also had their issues of getting biofilm on them, rubbing on the eye, and of course the biggest issue is they just extruded and didn't stay in, or you could get granuloma there too. So these dissolvable plugs have won the prize. Problem is the first dissolvable plugs are 1 month. I'm not going to replace a plug every month. So in the last 4 years, we have Oasis came out with a extended duration plug that goes for about 6 to 9 months. And I love their tapered plug because it goes down to 2 millimeters or 2.5 millimeters, and then it's 6. So you get full occlusion. And that little 2.5, I don't know why someone didn't think of tapering a plug years ago. Whoever came up with this is brilliant. It was not me. I wish I thought of that. You put the little tapered part in, and then you just push the rest in. It's instant, and it lasts 9 months, 6 months in some patients. That
And they
has
don't
been
back out. They don't back out as often as the standard size one is, who sometimes will float right back out. And
That's right. And you can actually take your dilator and just push them in just a touch more, and they never come back out. And then, as of about 6 months ago, Lacrofill. I have patients who say, "Hey, I noticed this plug is gone every 6 months. I've started doing some Lacrofills on them, and I've had great success with that too. They love the HA that's being released from a cross-linked plug, and so that combination of those two have really changed my view on punctal occlusion. That's me, and I guess you must have known that because you asked the question in the right way. So if you'd asked me that question 5 years ago, you'd think I never did plugs, and now, I mean, there isn't a procedure day where I might not have 20 plug patients on the schedule.
regarding the lacrophila, have you had to irrigate any yet, or not?
Not yet, but that goes back to what we talked about earlier, Bill. That you're looking at that tear meniscus. If it's normal, don't put a plug in there. It makes no sense. Even if it's releasing HA, you're looking for that thin tear meniscus height. That's the great thing about the Keratograph. It tells you if it's a 0.1, it tells you it's a 0.2, it tells you what's normal. If it's a 0.3, never put a plug in there. So I think because we're selecting the patients really well, that as we talked about, identifying the right ones, I've not had to remove one yet.
I'm going to throw a word out at you, and you tell me what your response is. Lissamine green.
Gone. I don't need it. I mean, number one, I learned this a strange way. So about 12 years ago, 10 years ago, one of my technicians named Janet, she was actually a photographer for Will's Eye Hospital. I got lucky because
Mm.
they ended up giving me her.
Relocated to you, yeah.
I lucked into it. So she's a super photographer, all this stuff. And Lissamine Green, yeah, I guess it was about 9 years ago, wouldn't even, because she's been with me 10. So maybe it's 10 or 9. Lissamine Green had a shortage and it was gone and we couldn't get it. I'm like, well, I'm not going to be able to practice dry eye without looking at conjunctival staining. So I'm like, and we had a group meeting and someone said, we can't get any more. And Janice said, well, why use than that? Just use like a number 15 yellow Ratten filter with your fluorescein, cobalt blue. I'm like, excuse me? She goes, oh yeah, you should be able to see staining based on the way the wave fronts. I don't know. She went into it. I'm like, I didn't pay enough attention. So about 3 weeks went by. I still never got around to it. Just busy life. So she bought one for me from a photography shop. She said, Dr. Peggy, just put this right behind the slit lamp, not in front of the oculars. That won't work. Your oculars have to be, your eyes have to be at the ocular, but right behind the slit lamp, not right in front of the patient, right behind the slit lamp, and look and see what you see. And I'm like, oh my gosh, this is lissamine. I'm seeing it with fluorescein. I said, how did you know this? Why didn't you tell me this 3 weeks ago? And she's so anyway, she laughed and she said, well, so we have one in every single lane. So that was lightning. Some people need a 20, some need a 12, but 15 is the one for me. And the funny thing was, about 6 months later, a year later, lissamine came back, but it went from like $80 a box to $480 a box.
Okay.
And I'm like, I don't need it. I've got this $9 filter that I use on every patient. And that's been the last time I used lissamine green, about 9 years ago.
One of the challenges that I hear from a lot of docs, especially primary care docs who want to get more involved in dry eye, is the challenge of a fast screening test during the routine examination to bring them back to that medical dry eye workup. What would you recommend of one or two or three things that they can do or the technicians can do, either with the keratograph or without the keratograph, that take limited time but give you the most valuable information, especially given the fact that signs and symptoms are often disconnected? And for me, it's a lot harder to treat a patient with no symptoms than it is to treat a patient with symptoms. So what are the few things you would do during a primary care routine eye exam that wouldn't clog up your flow of your whole day?
Yeah, one I would tell you I got from you, Bill, which is looking for the patient who's when you're trying to do a refraction, or the staff or the doctor's doing it, where they start have to blink to be able to get the image, or even to capture the keratograph, or any sort of pre-testing. They're blinking, or they're having to put something to kind of get a better image. I think we forget that part a lot of times, where we're doing a refraction and the patient's waiting and can't really tell, and they blink behind there, and you have to be looking for that. And you realize that's that visual disturbance that DEWS 3 was talking about. It's an instant diagnosis where you don't even need to do anything extra to be able to pick up on the fact and say, I know the reason why your glasses or contact lenses aren't doing what you're needing is you've probably got some dry eye. And then what are the easiest tests to be able to check for ahead of time? Because, in primary eye care, you don't want to be putting a lot of fluorescein in. You don't want to be doing a lot of stuff. If you have the time, honestly, meibography is so powerful. It's quick. You get a good image. You have a good idea of what's going on, who's going to drop out of contact lenses, who's not going to do well with cataract surgery, post-cataract surgery, dry eye, all those things we talked about. If you have the time, that's a really easy thing to do. But during your refraction, during any of your pre-testing, during keratometry, if things break up, those are your biggest indicators. The visual disturbance is really the whole emphasis of DEWS 3. And then if you back to that question, why they take osmolarity up? Because I think they're trying to get at the primary eye care provider. They're like, we don't need to be teaching the people who've been doing dry eye for 27 years like me. What are we doing there? They're on the committees. We need to get this into everybody else's hands and make it practical. And I think that's why they moved away from that and focused on visual disturbance and fluctuating vision and the whole visual, components that they listed twice in the definition and like 6 places after that, was really to say, hey, let's try to find those things in a routine exam to then tip the patient over. So you would still treat them with, and I'll tell you, my last one is really easy too. You don't need dyes or anything else. It's that really good eyelid assessment we talked about. 2 seconds maybe to express, but even if you don't do the expression, just looking for telangiectasia, looking for cap glands, looking for collarettes. Now, you start the patient on something who doesn't have symptoms, whether it's a drop or an artificial tear, a compress or a lid scrub or an XDEMVY, and then you say, hey, I've got to bring you back for a medical workup. So you still do the VSP, you still do what they came in for, you still do their primary exam, but then you bring them back for medical. And the great thing about this is I heard this from another doctor who showed that in their doctor system, big PE group, that patients who came in for the medical exam after that first VSP exam that was on a vision plan were 300% more likely to come in for their yearly visit. So once you move a patient to medical, you have them for life.
The other thing I've noticed too is resist wanting to treat them at that routine visit, because if you
Yeah,
start that treatment, they will could possibly disappear also. But wow,
yeah,
that is amazing information. I never heard that statistic, but that's an impactful statement for primary care doctors that you want your patients coming back every year, and if that's one of the ways you can ensure that, that's great information. Well,
yeah. I
Paul,
can't
we're at
think
the top of the hour, and I could
of,
probably go on all night with you. This is so much
yeah,
fun.
I do enjoy.
But
You're
I
so good
want to
at this.
respect, yeah, I want to respect everyone else's time. I'm going to close with saying thank you to Dr. Paul Karpecki for another amazing presentation. And again, you saw the slide on the super summer sale from Oculus is saving up to 20K depending on the instrument. It's an open box sale. There's a QR code there that you can scan if you're interested. And again, thank you from Oculus for everyone attending tonight. And we'll try to get answers to any of the other questions via email. And again, Dr. Karpecki, thank you. Have a great evening.
Thanks, Dr. Tullo. It's my honor.
All right. Good
Bye
night,
bye.
everybody.
Night.